Hey everybody, welcome. We're so excited today on behalf of CME Outfitters. I'd like to welcome and thank you for joining us. This CMEO snack series is supported by an educational grant from CVS Health. We're really excited to join you today to talk about Speaking with Care, Spanish Essentials for Patient Engagement. I am Dr. Jasmine Gonzalvo, and I have practiced just about 20 years and provided direct patient care in a federally qualified health center, providing care for people who primarily speak Spanish. So high cardiometabolic risk. That's primarily my patient population. I also serve as the director of the Center for Health Excellence, Quality, and Innovation at Purdue University. Today, I'm joined by my colleague, Dr. Robbie Mueller. Robbie, do you want to go ahead and introduce yourself?
Yeah, of course. Thanks, Jasmine. My name is Robbie Mueller. I'm a professor of pharmacy practice at Concordia University of Wisconsin School of Pharmacy. As part of my faculty role, I practice 2 days a week at a family medicine clinic in Racine, Wisconsin, where I see exclusively Spanish-speaking patients and get to work under a collaborative practice agreement to provide chronic disease management services through language concordant care. As far as my background goes with medical Spanish, I'll be brief. I'll just give you some of the highlights. Before pharmacy school, I graduated with a bachelor's degree in Spanish and Portuguese studies from the University of Minnesota. I've had the opportunity to use medical Spanish in the retail, hospital, and clinic settings, and ever since being on faculty at Concordia for the past 12 years, I've taught several different medical Spanish courses. And then recently, I've also been able to teach some medical Spanish courses for the medical Spanish concentration at Palm Beach Atlantic University School of Pharmacy. Aside from my teaching roles over the years, I've done some medical Spanish work in Mexico, Puerto Rico, Cuba, Peru, Spain. Um, I serve on the board of directors for the National Association of Medical Spanish and serve as the chapter advisor for our student chapter of the National Hispanic Pharmacists Association. So yeah, I'm really excited to talk with you today. Medical Spanish and caring for patients with medical Spanish is really my passion. So thanks for this opportunity.
Robbie, it's clear and obvious that this topic is your passion, and we're so excited to be having this talk with you today. So, with that, let's jump into our first objective. So, today for our snack discussion, we really want to focus on the integration of patient-centered communication strategies that incorporate appropriate formality, family engagement, and effective use of interpretation services. So that's what we're going to be doing first. We would also like to, as our second objective, apply plain language and medical Spanish communication techniques, including teach back to enhance patient understanding during multilingual encounters. So that's what we're going to focus on for our snack today. And I really want to start off by talking about two separate scenarios that I think help highlight some of these important aspects of speaking with care. And Robbie, do you want to go ahead and start us off with this sort of first scenario?
Yeah, of course. So yeah, there's a classic case of kind of being lost in translation, for I guess lack of a better phrase, and it involves the tragic case of a 18-year-old patient, Willie Ramirez. Willie was out with a friend one night when he experienced a headache. Shortly thereafter, Willie was taken by ambulance to a South Florida hospital in a comatose state with no apparent trauma. One of the doctors spoke to Willie's family to kind of gather a little bit more of the patient's history, and while he acknowledged that he had some problems understanding the patient's family, he felt the gist of the conversation was that Willie was upset about kind of a verbal fight that he had with his girlfriend and had taken some drugs. Someone from Willie's family described Willie as intoxicado, end quote. And the doctor assumed that intoxicado was a cognate for the English word intoxicated and treated Willie for a drug overdose. Neither the ER doctor nor the family requested a professional interpreter at the time because each side felt that they were communicating appropriately. But after nearly 2 days, Willie was no longer moving his arms, and Willie was transferred to one of the hospitals in South Florida at the time that did have a CT scanner. And the CT scanner revealed the troubling reality that Willie had not suffered a drug overdose, but rather had suffered a left intracerebellar hemorrhage or hematoma with brainstem compression as well as a acute subdural hematoma. Emergency surgery was performed, but it was too late to prevent the brain damage that left Willie with quadriplegia. The sad thing really is that this misdiagnosis was really in part due to confusion regarding the patient's medical history. And then at the heart of that confusion was language discordance because the patient's family and the physician were literally not speaking the same language. See, in Spanish, the word intoxicado is generally not equivalent to the English word intoxicated, as it was assumed by the physician. Among many Spanish speakers, intoxicado really refers to something that's wrong with you because of something you ate or drank. It's often used to refer to like food poisoning or food poisoning like symptoms. And on the day that Willie's symptoms began, he ate at a fast food restaurant, and his family assumed that he suffered a severe headache because of something he ate, like a bad hamburger, for example, so that Willie was, quote, intoxicado. So really this Willie's case is a stark reminder of the challenges faced by millions of people in the United States with a non-English language preference, and really I think shows that language appropriate care through either professional interpreters or through language concordant care with multilingual providers is not just a nicety, but it really can be a patient safety issue.
Yeah, Robbie, so much of what you said is really important, and your story really resonates in terms of, kind of the bad things that can happen when
Mhm.
there are language barriers present and we're not communicating effectively. So I have kind of a success story, right? We all
Yeah.
probably have some negative stories associated with this space. I do have a win, so to speak, for when we do kind of pay attention to these language barriers and we do things to address them. Some of the good things that can happen. So one example that I have is my colleagues and I did a study locally at our safety net hospital, Eskenazi Health. And what we did was add CGMs to our formulary.
Mm,
And we looked to improve access where access was previously a barrier. And what we found was really pretty exciting for the work we did to get the CGMs on our formulary. We found that improving access to CGMs, particularly in the Latino population, resulted in statistically significant improvements in A1C and adherence measures. And so this is a real life example of when we pay attention to what may be contributing to health disparities, and language barriers may be one of those things, that we can really see an improvement in health outcomes. We can start to move the needle on health disparities that we've historically been seeing in a variety of diverse populations, but primarily in our Latino population, when we really pay attention to what the barriers are, what are causing the barriers, we can actually see improvements in health outcomes. So we were really excited to see these results in our health system and across our FQHCs. And that was whether you were a pharmacist providing the care or whether you were a physician or other prescriber providing access. When the access to the CGMs improved, we saw the improved outcomes and the improved adherence. So a lot of times you may get into conversations as well that there may be a lot of stigma that
mhm.
improving access doesn't necessarily result in some of these improved outcomes or improved adherence. So addressing all of those barriers, paying attention to those barriers, particularly in our Spanish speaking populations, oftentimes can result in improved outcomes if we just pay attention and look at the data. So a nice success story for us to have amidst a lot of unsuccessful stories as well. So just
Yeah.
highlighting the good and the bad, right, Robbie?
Yeah, no, totally. That's a great example. I mean, yeah, we know that language appropriate care, language access is really the key to health equity. I mean, there's more than 350 languages spoken in the United States, and 67.5 million people speak a non-English language at home. That's 1 in 5 people in the United States. So language is a driver of health. I mean, it impacts outcomes, it impacts safety, and our focus today on caring for Spanish-speaking patients, I don't think is misplaced because of those 68 million people that speak a non-English language at home, about 41 million of them are Spanish speakers. I think it's also important to note that Hispanic individuals make up 63% of the population in the United States with limited English proficiency, or I guess to use a more accurate term, those with a non-English language preference. And that's significant because, like I said, we know from studies that non-English language preferences, those patients, they experience more errors, have lower patient satisfaction, and worse outcomes than patients with a high English proficiency. So yeah, it's important to care for this population well.
Right, Robbie. I don't think we can hit home that message clearly enough, right? With the information we're presenting today. And it's so nice to have data to support a lot of what we're saying. So a lot of this
Mm.
isn't just Robbie and I with our opinions, but there
Yeah.
is published data to support a lot of what we're saying. So knowing the benefits of, well, Robbie, I think you can provide a framework, kind of expanding on that evidence, right? So the essential legal and ethical framework behind what we're talking about. Can you expand a little
Mhm.
bit on that, Robbie?
Yeah. So I think it's important to know that it's not just the nice thing to do; it's also kind of like the legal and correct thing to do. So entities are actually required, like hospitals, for example, are required by law to provide care in a language that patients can understand. So even with the executive order designating English as the official language in the United States, there's still several statutes, laws on the books that the executive orders cannot overturn without Congress passing new laws. So specifically, we have the Title VI of the Civil Rights Act of 1964 that prohibits discrimination based on things like race, color, national origin, which really includes language for any program that receives federal funding. We also have the non-discrimination provision of Section 1557 of the Affordable Care Act, which further elaborates and codifies kind of protections related to language access and specifies that entities must provide meaningful access to language access services, such as qualified interpreters. Those services have to be free of charge, they got to be accurate, timely, and protect patient privacy. And it also specifically prohibits requiring or suggesting that patients bring in their own interpreter, using a child to interpret, except in life-threatening cases, and then relying on staff members who are not qualified as kind of bilingual or multilingual providers. There's also CMS guidelines and many state regulations that also require healthcare providers, including pharmacies, to offer language access services to patients with a non-English language preference.
Yeah, Robbie, that's really important, right? So thinking about the legal implications of not kind of um, doing the right thing in this space is really important for us to consider as well.
Hmm.
So looking at more of the evidence, the benefits of language concordant care, we know that there are benefits, again, according to the evidence. There's a systematic review that shows that in language concordant settings, there's a significant improvement in reduction in A1C, LDL, and blood pressure in diabetes and cardiovascular studies. The majority of the research, about 76% of studies, showed better outcomes when patients and providers share a language. So that's a really convincing, those are convincing data that really shows us the importance of language concordant care and what can result as as a result of language concordant care, right?
Hmm.
So Robbie, I know you can talk a little bit more about kind of this idea of false fluency.
Hmm. Yeah, so I'm a really big advocate for empowering and encouraging multilingualism in the clinical space, and yet it at the same time, on the flip side of the coin, maybe it's important that we avoid false fluency. So, in our context, I guess in the medical realm, false fluency would really be when you believe you're communicating appropriately and have enough language skills to provide that language concordant care, speaking the same language as the patient, but you actually don't have the appropriate skills. So there are some red flags, some indicators that we might see that could maybe tip us off that this could be the case for us. Having some word finding difficulties, like you can't think of the appropriate word or phrase to describe a concept, would be one example. If a patient displays a lack of understanding, like when you use the teach back like method and they display a lack of understanding and you're unable to rephrase or reformulate the concept or instruction in a different way, that could be another kind of red flag indicator of false fluency. If there's a lot of patient editing, so what I mean by that is that the patient is having to edit what they say or significantly lower down the speed that they're talking in order for you to understand. Or if the patient provides you with a confusing answer to a question you ask, or asks a really confusing question to you that really seems out of context and not really aligned at all with what you're talking about, those would all be indicators that you as the provider are maybe exhibiting some false fluency. Um, and I do think it's important to know that, just using some Spanish is not then, better for patient care than using none at all. I think a lot of people have good intentions about like, oh, I want to use the language skills that I have, but medical literature suggests and demonstrates that despite their desire to improve patient care, medical residents and medical students with limited Spanish proficiency, when they tried to use those limited skills in patient care, they were prone to having some errors. That it's probably makes sense, right, that with limited language skills that can increase the risk of having misunderstandings, medical errors, and it can decrease patient satisfaction as well. A classic example of this is like the medication instruction, right, like take once every day. Right, so it's like, oh, okay, like I know some Spanish, right? I know take would be like tome, once, once, that's a word in Spanish, and then cada, every, and dia, day. So take once each day, tome once cada dia, right? The problem with that is that once, once, well, yes, it is a Spanish word, does not mean once like it means in English. It means 11, right? So it means take 11 every day. So there's, a big difference there. I have numerous examples of this in my clinic too, that I've just looking at patients' profiles. I see medications that they were prescribed, and I can see providers, trying to use Spanish skills like writing the prescription, but it really sometimes creates more errors and potentially more harm than good.
Right, Robbie. I think, both of us in academic settings, we work a lot with students who'll be like, I have some high school Spanish, and they get kind of excited to think
Yeah,
that maybe, oh, I think I can do it. And I'm guessing we're like-minded in that space of like, let's maybe
yeah.
practice behind the scenes, not with direct patient care. And, I kind of give my students some role playing and opportunities to do that with me. But then when it
Hmm.
comes to the direct patient care, it's a different story. We can't
Yeah.
just kind of allow them to practice because of the harmful things that can result.
Hmm. Yeah, and I feel like usually the heart's in the right place, right? Like I want to use the skills, I want to do this, but yeah, it can become a patient safety issue. Um, so one of the things that I recommend as far as like, hey, am I good enough, for example, to speak Spanish with patients and provide that language concurrent care, is to do a quick self-assessment. So there's actually a one question self-assessment called the ILRH, and it is a scale that uses the ILR scale but adapted for healthcare providers. Um, And it's been shown through studies to be comparable in accuracy to validated oral proficiency interviews. At the lower and higher ends of the scales, it's not as reliable, it's less accurate in the middle range. But the FAIR level corresponds to low to intermediate level, according to the American College of Teaching for Foreign Languages proficiency guidelines. So I think that's a good place to start. And if you self-assess then as poor, fair, or good, then I would recommend limiting using your language skills to really just building rapport, kind of basic readings, pleasantries. Even that partial language concordance can help build rapport and can be useful. Um, and I know, Jasmine, you and I have talked about this in the past, and there might be some additional tasks and things that we can give to learners with, maybe a little bit more of that like intermediate proficiency. I would just maybe offer kind of like a potentially guiding principle of if a pharmacist, if it requires a pharmacist to do it, right, that person then should have either use a professional interpreter or be, qualified enough to provide language concordant care. But if it's something maybe that a technician could do, maybe some basic prescription intake or checking out a patient for like a refill, or we've talked about like showing videos to help guide patient education. Those are things that I think someone with a more limited proficiency could do. But if you're very good or excellent on that scale, then I think you can consider providing language concordant care. There's some additional factors that I think you want to consider. Using a professional interpreter is still always an option, but I think you're at a good starting place. Then if you self-assess as very good or excellent, from that standpoint. And if you want, I can kind of like walk you through, I guess, like a kind of how I process, or I think like an illustration for like when to use an interpreter or not, if that would be
Yeah, I think I think
helpful.
that would be great, Robbie. I think I just want to kind of uplift one of the things that you said that I think
Hmm.
we'd be remiss in not really highlighting here is
Yeah.
the building of the rapport. I
Hmm.
think that that's actually where my students have the most opportunity when they're like, hola, ¿cómo está? And then
Hmm.
and then they're like, that's it. That's all I
Yep.
got. And I don't
Yep.
know what you're going to say back to me and I don't know how to respond. But I find that a lot of our patients in clinic, will smile at that because
Hmm.
they know that that's all the student has, right?
Right.
But it actually goes a long way
Absolutely.
to the rapport piece of it, right?
Hmm.
And there's little to no damage that can be done from really kind
Absolutely.
of just being friendly and kind of smiling and saying like, no, I don't really speak Spanish, but I just kind of wanted to try, right?
Hmm.
So there's a really stark contrast of when you're actually providing really important recommendations and where safety can be at risk with language discordance versus I'm trying to be pleasant and have a moment with you to build rapport,
Hmm.
really in a not posing any safety threats
Yeah.
to patient care. So
Mhm.
yes, let's Robbie, I'd love to hear kind of you walk through when working with interpreters is really appropriate.
Yeah, great. So, yeah, I would say that the first kind of like question you could ask is, do I speak the patient's preferred language? And if the answer is no, then yeah, use a professional interpreter. If it's yes, then again, ask yourself, at what level am I? If you're using that ILR H scale, are you excellent or very good? If you're below that, then I would say, again, request a professional interpreter. If you're very good or excellent, then I would ask yourself, do I meet my institution's, my organization's qualifications to provide language concurrent care? Depending on your institution, you might have to pass a test first or have some kind of training or certification in order to do it. So kind of ask yourself, have I met my organization's requirements? So even if you are bilingual native speaker, but you haven't met your organization's requirements, then I would say request a professional interpreter. If you have met those requirements, then I would, final question I would kind of ask myself is, do I feel comfortable in this specific situation, right? Like language is a very kind of dynamic thing. So even if you're a native speaker, qualified, certified in doing it, but it's a really it's a high risk situation. Maybe you're talking about end of life care or like a new diagnosis of like cancer, something like that. It still might be best to lean on the expertise of a professional medical interpreter. But again, if it's something that like, hey, I'm qualified, I've been certified through my organization, and my task right now is to provide patient education for this lisinopril prescription, for example, that I'm quite familiar with. And yeah, great, like that's a great opportunity to do that. But like you said, Jasmine, even at the basic kind of like level, greeting a patient, saying hi, using titles like senor, senora, and like their last name, that can really go a long way in building patient rapport.
Right, Robbie. All of that's so important. I think it's so nice, especially as pharmacists, to kind of have that flow chart of like, how do I really make this decision?
Mhm.
And how can I answer questions, yes or no, to really make sure that I'm taking care of the patient? So thanks for that sort of
Yep.
breaking down of the thought process of what may be most important for patients and appropriate. I think it's also really important to think about some cultural nuances here. And this
Mhm.
isn't necessarily specific to Hispanic or Latino cultures. We can
Mhm.
see this across a number of different cultures, but these are definitely things that may be more important for our Spanish speaking patients. So when we're thinking about, and Robbie and I have said this throughout, but building connection and small talk fostering
Mhm.
trust, where maybe those lower levels of being able to engage in speaking Spanish can really actually matter quite a lot, and sort of result in an interaction that's just very casual, comfortable. And like I said, it's not necessarily specific to Spanish speaking patients. You don't just even if it's in English, you don't just say, what are your sugars? Like the first
Mhm.
thing in
Right, right.
when you walk into an appointment, right? You
Mhm.
do sort of like ease into it and create safety in the space. And that's
Mhm.
no different than what you want to prioritize for your Spanish speaking clientele as well, right? So
Absolutely.
without that sort of tiptoeing into without the small talk, you may lose a sense of trust, or kind of that space where a person really feels comfortable sharing what's going on with their health.
Mhm.
So familismo, right? This idea of really engaging family may
Mhm.
be important. Still with the idea of using the interpreter for accuracy, like Robbie was talking about, is important. But the idea of just engaging whoever may be at the appointment as appropriate, obviously. So and then respeto, no? So using
Mhm.
usted instead for the form of respect versus the to form.
Mhm.
And for those of you who are familiar with that idea, the usted form is really just showing more respect versus familiarity with your patient. And so default to that usted, just so
Mhm.
you're you're kind of defaulting to a more respectful approach, right? Um,
Mhm.
and then maybe your relationship over time does kind of develop into more of a through familiarity. I
Mhm.
know I definitely have that with some of my patients. It really feels like more of a through, and it
Yeah.
wouldn't. It feels too formal to
Yeah.
be in the
Right.
kind of usted space. And you
Yeah.
all know who I'm talking about. The patients you've been seeing for a really long time. They're telling you
Mhm.
about their granddaughter, that type of thing. And
Yeah.
so at some point, it may be appropriate to use the to form
Mhm.
instead. So, Robbie, do you want to tell us a little bit, kind of more about colloquialisms and maybe patient-friendly language?
Yeah, I'd love to, and maybe just to piggyback too on something you said, Jasmine. There was a study that came out that asked Latino patients like, what are some of the important factors that you consider when choosing what pharmacy you go to? And the number one thing, more important than the pharmacist being Hispanic or Latino or even speaking Spanish, was that the pharmacy employees are respectful. So I think again that just really hits home that point of respeto and using the usted form, greeting the patient, just being kind and warm just really goes a long way. One one other thing that is related to respeto is this kind of use of colloquialisms or informal language. This is a little tricky though because some of the informal language can vary a lot depending on what region the speaker is from. And I often I try and encourage my students to kind of use a balance, and at times depending on the word I'll often tell them to maybe start with a kind of the most universal or kind of like general medical term, and kind of lead with that, but then kind of mirror the patient's language. So if a patient then uses a regionalism, a colloquialism, some more like informal term to kind of mirror that back to them, to use their own language with them. So that I think is just a good kind of common rule of thumb of to use patient friendly but kind of medical like terms, so kind of lead with that, but then respond by mirroring the patient's language. Some other, I guess, kind of like tips and kind of nuances there with colloquialisms is that there are some words that can be a little problematic or challenging. Constipado is one. So constipado, sounds like constipated, but it's not. It really refers to more just having a cold. And I had this very example happen to me when I was studying abroad in Spain, and I had a cold, stuffed nose, sore throat, I'm sneezing all the time. And then my host dad was like, Roy, estás constipado? And I thought he's talking about constipated. I'm like, no, no, like everything's good. Like I got a cold, I got a sore throat. And he's like, yeah, estás constipado. And I'm like, no, I'm good. I'm good there. But yeah, so constipado generally means having a cold. Due to the influence of English, sometimes though patients will kind of use it in that cognate form that constipado means constipated. So I'd say if a patient uses it, always best to clarify. But I always tell my students like don't use it to refer to constipation. You can say estar estreñido, estar tapado, or just tener estreñimiento for to have constipation. Another, while we're talking about the bowels, diarrhea and diarrhea and empacho are some other ones that have a lot of informal terminology associated with it. And actually, it's oftentimes the respectful thing to do to use some of those regionalisms or euphemisms, like hacer popo to go poop, to go poopy, is actually a respectful thing to do than using more kind of technical terms like defecar or evacuar, right? So kind of bringing it again down to the patient's level. So empacho is another kind of tricky one that can sometimes refer to what is called in the literature like a folk illness or a cultural bound syndrome that often involves a lot of digestive issues like nausea, vomiting, stomach pain, and it's thought to be caused by overeating or consuming something that's difficult to eat. And the thought is that maybe like food is like sticking to the stomach or the intestines. So there's some treatment remedies for this that usually involve like herbals or using certain techniques to kind of clear the perceived blockage. So it's even if you're not using these words, it's sometimes helpful to be familiar with the words and their related concepts like folk illnesses. There's also just again a handful of kind of technical terms and then more kind of colloquial, informal ones that you can consider. So something like I already mentioned hacer popo for to have a stool to go poop, or orinar to urinate, hacer pipí to go pee pee, hacer de uno. Those are some other kind of colloquial variations that again can help the patient feel more comfortable than this kind of super technical patient terminology.
Thanks for that, Robbie, because I think, especially as pharmacists, in school, we learn to speak professionally, right?
Right,
And so, some of the examples to go poop, right? Like
right,
aren't necessarily going to be natural for us to just kind of like
absolutely.
switch into that sort of more casual language. But I think it's nice that you're essentially saying like, no, 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 this may be the most appropriate way to
Hmm.
communicate sometimes. So kind of
Yep.
getting a read on those things is important. really like that. I don't want to spend too much time on this next slide about practical access and getting a qualified interpreter. I think you all know and listening is well, maybe you don't know and maybe you should check, but what are your access to qualified interpreters? I think one of our most important things that we need to do is to be able to document the interpreter name and ID at each and every visit. So you kind of have that documentation trail. Does your note template really make sure that that's documented consistently every time? And depending on, kind of what service you're using or what access you have to a qualified interpreter, just making sure that you have a really consistent way of documenting that avenue of interpretation. So the other things are here for you to read, but probably I think um, what to do and not to do is an important discussion that we should probably have
Mhm.
next.
Yeah, great. Yeah, I agree. So I think maybe one of the most common mistakes is using family members or minors to interpret outside of emergency situations. So I think that the guidelines in the literature is quite clear on this, that ad hoc interpreters, such as family members, should not be used unless it's an emergency. And there's a variety of issues for this, not least of which is that ad hoc interpreters are not trained to interpret, they're not hired to interpret, and they're not compensated to interpret. There's also a lot of ethical issues that can pop up too when family members are interpreting, again, depending on, what the potential issue could be, right? So, if, in the grave scenario of like domestic abuse, right? Do you want a spouse potentially like interpreting for someone, right? When that's kind of, part of the issue. So there's a lot of ethical things that could pop up. I would say the other thing that often comes up too is with multilingual students kind of being asked to interpret. I think this is also inappropriate too, because it really conflicts with the learner's learning responsibilities too, as well as it's a different skill to provide language concordant care and to interpret. It's just they're different things. So to interpret for someone, right, you're not controlling at all the words that are coming out of their mouth, right? So providing language concordant care where you're coming up with the language is a different skill. So I think it's inappropriate for us to kind of put that on students. Uh, AI and Google Translate is always a hot button issue. And while I think these things are getting better as of right now, the literature still doesn't support using them. There was a study done in 2021 that looked at Google Translate, and it showed that it was only accurate 80% of the time for medical phrases. I mean, it's a lot better than the 57.7% that it showed back in 2014, but it's still, 80% isn't reliable enough, for us to be using in practice. So, and I don't think we should be mixing languages on patient labels like my previous example. It really should just be in one language. And then I also think we really need to do a better job about documenting patients' preferences about language, just in general. Asking a patient, do you speak English? Is maybe not the ideal first question to ask. Language needs can be dynamic and depending on what situation you're in. But what languages do you speak, or what languages do you kind of like read? Is a good thing to have on a patient's profile. But again, language needs are so dynamic. I encourage my students to kind of like ask in like a clinic setting, in what language do you prefer to receive care today? Right? Because picking up a refill, uh, English might be fine. It might be your preferred kind of way of communication. But if you're going to receive, new patient education on warfarin, for example, hey, maybe receiving that in your preferred language would be the best option there.
Yeah, really, really good things to think about, Robbie. And I think we'd be remiss in this presentation if we didn't at least talk a little bit about implicit bias, right? That
Mhm.
might come up. And really what we're referring to is kind of what's going on subconsciously in our attitudes that really may affect our behaviors, right? And so in the beginning of the presentation, I mentioned that, we were looking at CGM access for our FQHC population, right? And what we
Mhm.
found was that improving access really did result in improved outcomes. So what we want to ask ourselves in these situations where we're working with diverse populations, particularly where there are language barriers, are implicit biases. Oh, I'm going to work with this patient and I need to work with an interpreter and it's going to take so much longer. So I'm not going to do half of the things I need to do because it's going to take double the time with an interpreter.
Right.
That could be kind of in the space of implicit bias of, I'm not going to provide the level of care that I normally do because of the
Mhm.
length of time it takes to work with an
Right.
interpreter. Or also like what that impact is on the patient experience. Like, am I not using, for example, I'm a huge proponent of motivational interviewing, right?
Yep. Right.
Am I not going to do motivational interviewing and because I need to do that speaking Spanish, right? Or is
Mhm.
it just it takes longer, it's clunkier, all those things, but
Yeah.
that can all of those ideas kind of enter into this implicit bias in pharmacy practice and really may impact patient care negatively. So
Yep.
really doing a lot of self-reflection in this space of am I providing care in a different way that
Yes.
perhaps I
Absolutely.
would do I would go the nth degree. I would take the extra 5 minutes if I were speaking English, but because I'm speaking Spanish, I'm not going to do that because
Mhm.
it takes longer with the interpreter because I don't have the words in Spanish, kind of like what you were talking about, Robbie. So
Mhm.
those are the things that we really just need to have a lens on to make sure that we mitigate any potential for implicit bias as much as possible. We're all going to have it. We just need to be aware of what our biases are
Yep.
and what we may be able to do to really mitigate the influence of implicit bias. And
Yep.
so, Robbie, I just kind of want to, as we're sort of winding down in this presentation,
Yeah.
I'd love to hear just kind of like a practical example from clinic from you.
Yeah. I guess on that topic, I mean, I've kind of experienced and witnessed this kind of thought that maybe assuming that a non-English language preference like means at the same time low health literacy, right? And just because maybe you don't speak English that well doesn't mean your health literacy is, low as well. So I think just not to conflate or combine those two. Um, and then, just thinking that, someone who does speak Spanish actually wants to speak Spanish. I had this happen just the other day with a 28-year-old patient, and on the profile it says, speak Spanish and, use an interpreter. So, with again, I can provide language concurrent care. So I started, I started talking to him in Spanish. And then he actually asked me like, "Hey, can we actually speak in English for this? Because I'm, newly diagnosed with diabetes." And he's like, "I've just been, uh, immersed in all this like new like vocab related to diabetes, but it was all in English, and he didn't have the medical terminology in Spanish for these things. So even though he's a native Spanish speaker, because he kind of recently received all this kind of like medical terminology in English and became familiar with it, he actually preferred to speak in English, right? So again, just I think that's a maybe a good example too of just because a patient can speak Spanish doesn't mean that they necessarily want to speak Spanish. So again, always asking the patient their preferences um, is a good foundation.
Robbie, I think it was so important for you to say that after everything we said. It's like,
Mhm.
assess all of these things to know whether you should speak Spanish and then really also ask the patient if they want to speak
Right.
Spanish.
Right.
So I
Yep.
think that that's a perfect way to kind of we're getting into our wrap up. I would love to hear kind of just like a final thought from you and kind of a
Yeah.
quote to end on.
Yeah. So I think we often, and I am probably guilty of this as well. We often hear about in healthcare patients having a language barrier, right? But I would just I guess encourage people to think that, maybe it's not the patients that have the barrier, and if anything, maybe it's the healthcare system that has the barrier, and the patients are just speaking their language. And language itself is not the barrier at all. Language is really a tool that we can use to provide patients the best care possible in their preferred language so they can achieve their best outcomes. So I just say language isn't the barrier, patients don't have the barrier, like language is a tool, and we should use it to care for patients well.
Robbie, that's amazing. That's a great way to look at it. And I think I even used language barrier earlier in the presentation, and I think that
I might have
even
too.
makes me sort of reflect on that use. And actually, the language is such like a beautiful piece of it, right?
Mhm,
So Robbie, I love that. And for me, I think my final thoughts really just sort of what I've already said, but just that it's on us to look within ourselves and make sure that we provide the best patient care. And how we do that is building rapport, is taking the extra time, is doing what's necessary to ensure that people feel safe and receive the best care and have improved health outcomes. And that's on us. To
mhm,
make that commitment. And so much of what Robbie and I have talked about today kind of give you those avenues and those tools that help you reflect on, are you really providing the best patient care for this patient population that we've focused on today? So it's been great to spend this time just highlighting how you may be able to do that. So those are our final thoughts. Just one more thing with SMART goals so that you walk away with something sort of tangible that you can put into action. So considering the following goals, setting a time frame that works that fits with your work environment and a reasonable improvement target that aligns with your patient population. So SMART goals are specific, measurable, attainable, relevant, timely. And so we've listed some here for you that you can read, that you can potentially walk away from this presentation having set some of these goals yourself, so that it really does feel like we've made an impact here. So whether that be, so for example, if you look at the relevant one on this slide, in every multilingual patient encounter, I'll apply plain language and teach back techniques to confirm understanding and strengthen trust. That's a very relevant goal that's just an example for you to consider.
yep.
So please walk away from this identifying your own SMART goal so that we can really feel like we made a difference with this presentation. So please see the wide range of resources on the CME Outfitters website. The CMEO Health Access and Social Responsibility Hub also has more resources to help increase your skills in fostering a welcoming, fair, and inclusive environment. This program is part of a broader initiative focused on helping pharmacists and pharmacy technicians enhance culturally sensitive communication with Spanish-speaking patients. I will be moderating other programs in this series, including two with Dr. Maria Hearns Rivas as well. And to receive credit for this activity, please complete the post-test and evaluation. We appreciate your feedback and want to hear from you. Tell us what you liked, how we can improve, and what additional topics you would like us to address. And I really want to thank you for spending this time with us. Robbie and I really appreciate you taking the time to learn about the topics that we talked about, and really just the ideas that we are improving care for our Spanish-speaking patients. And hopefully you took away what you wanted to from your participation today.
Yeah, thank you so much for this conversation, and thank you for your time, and